Nick Majerison here, and welcome to Top Med Talk. This is a conference highlight taken from our coverage of Anaesthesia 2018, the international meeting of the Royal College of Anaesthetists. It's presented by Joff, Lacey and Monty Mythen, and it features two guests who were about to debate the following topic. Direct laryngoscopes should be consigned to history. That was the title of the debate, and the two people debating it were Professor Tim Cook, consultant in anaesthesia and ICM at the Royal United Hospitals, Bath, and Dr. William Harrop-Griffiths, St Mary's Hospital, Imperial College Healthcare, NHS Trust. Listen as the two of them argue their point of view.
We're going to debate later on today. It'll be a fantastic debate. I think the result is kind of inevitable. I mean, let me just lay that out right from the start.
That you'll win.
But one of the problems with putting this within a debate context is that you make people take extreme views. Because the truth of the matter is not, will video laryngoscopy take over and direct laryngoscopy never ever be used, or video laryngoscopy is an appalling thing that we should never use and stick with direct laryngoscopy. The truth is in the middle. One of my main issues here is that we as anaesthetists love new bits of equipment. Yes. If they've got many buttons, we love them even anymore. If they've got a video screen, we love them even more than that. The more high-tech the equipment, the more we love it. The more we adopt it very, very quickly, we embrace it, we run with it, we use it, and we go straight from that point of new technology to, I want to use it for everything. I'm just advising caution. I'm saying there is a role for video laryngoscopy. There will be a role for video laryngoscopy as part of our armamentarium for airway management, but it is not the whole thing. It's not the whole deal. You can't ignore direct laryngoscopy.
And maybe I'll bring Tim in here, but my understanding is that the weight of evidence goes in line with video laryngoscopy for optimal view, and therefore you maybe say if you're going to get the best view with something, maybe that should be your first line.
That's my view, and that's what we've been doing in my hospital in Bath, or the hospital I work in Bath, for the last 5 or 6 years. So we now have video laryngoscopy as our first line routine for intubation in intensive care, in anaesthesia, in the emergency department, and we're moving towards doing it also on the wards.
So on an elective routine list with no evidence of difficult airway, this is your first.
I also wear a seatbelt when I drive. I don't just put it on if I think I might crash.
Nice analogy.
So video laryngoscopy is better. I believe it's safer. The perils of not getting intubation right first time are very significant. And as soon as you have one failed intubation, the risk of complications increase about sixfold. So I don't think it's a device that really should be used as a rescue device. I think it should be used routinely. The other important factor is that if you don't know what you're doing with a video laryngoscope, you gain no benefit from it. So a meta-analysis we published about 3 years ago showed that if you were inexperienced with a video laryngoscope, it provided no benefit. But if you're experienced with it, it decreased failed intubations about threefold, and that's been reinforced by another systematic review since then. So getting it out when you're in trouble, using a device that you're not very familiar with, it's a bit daft, really, like trying to put your seatbelt on as you're skidding across the motorway.
But on that note, isn't that one of the problems of video laryngoscopy, in the fact that I could go from trust to trust and encounter a totally different piece of technology each time, and therefore my ability to become an expert, it gets harder and harder?
I think there are lots of challenges. I agree with that. I think so what is clear is that when we talk about a supraglottic airway device, there are lots of different devices with different performance characteristics. They're not all the same. The same is true of video laryngoscopes. And it's my view that there's some rubbish on the market and there's some good kit on the market. And probably the best device to use routinely is a device which you can use as a direct or video laryngoscopic device to start with, and then if you have difficulty, then convert to a hyperangulated blade. So there are two devices which that applies to.
And so the device you have, you can use as a standard direct laryngoscopy as well?
Yeah, so there are two companies who market devices which are Macintosh blade video laryngoscopes. The evidence is that using that device, you'll get a better view of the larynx and intubation will be easier. If you want to use direct laryngoscopy doing that, you can do, but video laryngoscopy is probably better, and it's certainly better for the other people in the room to be able to see what's going on. If you then have difficulty, and I mean even a little bit of difficulty, then you can then change to a hyperangulated blade, which will reduce your failed intubation significantly. I think the next stage we need to move on with research is we've established that video laryngoscopy improves intubation, reduces failed intubation, and generally makes things safer, but we haven't established which are the best devices yet.
So, Tim, I'm still agnostic on this, so I'm looking forward to the full debate. I find both sides compelling. I'm slightly in favour of your version of the argument, since in our trust we had an event that cost somebody their life, and possibly the approach you're proposing, that would not have happened. But how do we keep the skill sets up? How do we get the balance of keeping the skill sets up? Because what happens when the video laryngoscope isn't available or doesn't work, or the bits aren't there? Or how do we get that? This
is really interesting, and it's a very common question. Are we de-skilling? So there's two aspects to it. First, are we de-skilling people? No, is the simple answer. There are 3 separate randomised controlled trials that show that if you train novices in direct laryngoscopy with a video laryngoscope, so the trainer can see what's going on, etc., then you improve their direct laryngoscopy skills better, more than if you use a direct laryngoscope. And the second thing is, it's about the patient, it's not about the anaesthetist.
If you choose a device that is a variation on the common blades as opposed to a very different device.
And that's why I would advocate for routine use, you do that. So if you're just using a video laryngoscope as a rescue device, then the logical thing is you pick a hyperangulated one, because you failed with direct laryngoscopy. But if you're going to embed it throughout your practice and use it for training, it makes sense to me to use something which is, as we call it, VL/DL, with a hyperangulated blade as backup.
Now, I'm going to follow up on your comment, Monty, because I think we saw with the laryngeal mask airway the introduction of a new technology and an associated skill set that very, very quickly took over from the established technology and skill set, which was the old-fashioned mask and airway, and we lost those skills to the detriment of ourselves, but more importantly to our patients. And I would not want to see us rush headlong into video laryngoscopy for fear that we will lose certain skill sets that only after they are lost we'll come back and saying, oh dear, well, that happened because they weren't trained in direct laryngoscopy.
Well, this is a recurring theme, I feel, that this welcoming advances in technology that may be at the detriment to a skill set but are better for patients.
Yeah, Will's comment is not backed by any evidence at all. And I remember the same debate about anaesthetists should not be allowed to use a laryngeal mask for the first 6 months or year or 10 years of their training. Of no benefit to patients. Mask ventilation is intrinsically less good than a supraglottic airway device, so let's do what's right for the patient. And I think video laryngoscopy, there's a very similar argument with that.
I think one has to be careful about an academic's total reliance on published papers, and I think that we, as clinicians with our feet firmly on the ground, have to look at our own widespread experience. Go and look at some of the younger anaesthetists now trying to maintain a basic mask and airway at the beginning of an anaesthetic. Watch the Goodell airway fly in within less than a second. Watch the 3-handed or even 4-handed airways that did not exist when people as old as Mythen and myself were trainees. Watch the increased anxiety about maintaining an airway with a mask and airway. There is a loss. There may not be papers to say that there is a loss of a skill set, but we see it on a daily basis. There may be people blessed, like Professor Cook, with phenomenal skills across the range, but we are talking about providing people with a basic skill set that when all else fails can rescue a patient.
But is there any level 1 anecdotal evidence, if such a thing exists? Are there legal cases? Are there claims bases? Are there shared anecdotes whereby the loss of that skill was the critical component of the patient being harmed? I see where you're coming from, Will. I'm with you. I was brought up that way, and the ability to use one hand to provide a great airway in almost every patient.
NAP 6 was not full of cases of failed mask ventilation.
But
it was full of cases of difficult or
and
failed
NAP
intubation. So NAP 4, yes.
No, that's just, you need to get your naps right.
I see, yeah.
I mean, you may not have had much to do with them, mate, but you've got to get the numbers right. And also, okay, I can show you, anybody can show you papers to prove or disprove any particular point of view that you want.
Getting very close to saying we don't need experts and we should ignore all the evidence, but keep going.
Well, we can do without some experts, Cook, but there you go. The two great advantages of video laryngoscopy that it gives you a good view of the larynx without a direct alignment. But there are also the downsides of video laryngoscopy. You get such a good view of the larynx that you're convinced you can get that tube in, and you will keep going until you get that tube because you can see the larynx. And I can show you papers that says it takes longer to intubate, a greater instance of hypoxia, which then leads to a greater instance of death for people with head injuries. Also, you don't get to see the bits in the corner. You're going round the corner because you're not aligned. You don't get to see the pharynx or the hypopharynx clearly. And all your tube manipulation is in the dark bit that you're not seeing. Right, and I will show you papers during the debate to show that there's a significantly increased instance of pharyngeal damage with video laryngoscopes. I'm not saying they're terrible. I'm saying that we mustn't say they're wonderful and must be universally adopted. We need to take things at a sensible pace.
Top Med Talk.
This piece was taken from a longer conversation to be found under the title RCoA 12, Should Direct Laryngoscopes Be Consigned to the History Books? If you go to topmedtalk.com, you'll be able to find it under that title. That's topmedtalk.com. Do remember you can meet the Top Med Talk team when we're going to be at the results of the Extreme Everest Symposium, June the 14th, live from Duke University in America. And of course, we're at all of the EBPOM meetings. Check out ebpom.org and find out how you can meet the Top Med Talk team.